Okay. Hi, this is Dr. Richard Bernstein with our first teleseminar of the year 2021. This is Dr. Bernstein's Diabetes University. Before we answer questions, I want to go through a few special subjects. The first is an article that appeared in the American Journal of Medicine. It's actually not released yet. Well, scratch that. The first is an article that appeared in the American Journal of Medicine on January 1st, 2021, and it is entitled Association Between Egg Consumption and Risk of Cardiovascular Outcomes, a Systemic Review and Meta-Analysis. So it's a look at many studies. That's what a meta-analysis is. And apparently they tried to compare people who ate no eggs to people who ate 1 egg a day up to people who ate 4 eggs a day. And the more eggs they ate, the lower the risk of adverse cardiovascular outcomes. This is just the opposite of what had been taught for many, many years and what many physicians and endocrinologists still advocate, that you should cut down on cholesterol intake, especially eggs, and because cholesterol intake adversely affects the heart. And it turns out that this meta-analysis shows exactly the opposite. And I've been maintaining for years that egg intake and cholesterol intake do not adversely affect the heart. Now it shows that they're beneficial for the heart. There was a question in today's batch that was very wise and probably important. Someone asked, which is a better indicator of kidney function or glomerular filtration rate, measuring serum creatinine or serum cystatin C. And as far as I can determine, it's probably a good idea to look at both of them because there are shortcomings to both. Some of the kits for measuring cystatin C in the clinical laboratories give different results than other kits. And serum creatinine can vary depending upon what you ate. In fact, if you have a full meal just before the blood is drawn, you're more likely to get a lower serum creatinine level than if you were fasting. Also, if you, since creatinine is, and serum creatinine goes up with muscle breakdown, if you've been doing a lot of exercise, you're likely to raise your serum creatinine. So I tell patients, for example, if we're going to measure your serum creatinine, we shouldn't exercise for, let's say, 4 days before the blood test. So all in all, it probably makes sense to check both, to not exercise for a few days before the blood test, and use the two tests for comparative purposes, to compare with what they were, let's say, 6 months prior, rather than relying on the absolute value today, because there may be some variation that's unrelated to kidney function. Last subject relates to pens. As you know, I've been pointing out problems with insulin pens, and I discovered only recently, even though I've been using pens for a long time, uh, I've only, and I'm not using them because I'm advocated. I I use them because of my vision. It's easier to turn a clicker than to look on a syringe uh, to measure the dose. But there's a problem, a major problem with insulin lost when you give an injection with a pen. I pointed this out before, but my recent discovery is that the loss is greatest for small doses. Here I've been advocating smaller doses of insulin all these years, and it turns out if you're using a pen and you give a small dose, you're more likely to get leakage from the injection site. And I believe that that has something to do with inertia. I just took a pen apart, and this forward section is what contains the vial of insulin. And when you give an injection, you're propelling a black, I call it a snake. It's a plastic plunger that has a spiral carved around it. You can see it coming out of the pen. And let's see. If I rotate the pen like I'm doing, the plunger comes out rapidly because there's a spiral cut into the plunger. And when you give an injection, you're forcing this spiral carved plunger through an odd shaped hole, and you're trying to do it with high velocity so that you can get the insulin squirted deep into the subcutaneous tissue. But because of that spiral, the speed of movement of the plunger is inhibited, so that the force that you're pushing with your finger is lost, some of it is lost to friction, so that you're not giving the momentum to the liquid material that you would with an insulin syringe. And the net result, and if you're giving a small dose, you're only imparting a small momentum to the liquid, and it might not go all the way fully into your subcutaneous tissue and might leak back out. So that's yet another reason for leakage from the pens. And I can't tell you, don't take small doses. What I do tell you is, if at all possible, switch to insulin syringes. Virtually all of my patients are using insulin syringes, not pens, because they want to get accurate dosing. Now we're going to get to the questions, but before we answer the questions, I want to remind you that the answers I give are generic answers meant to educate the entire audience of many tens of thousands of people, and they may not solve the particular problem of the individual who asked the question. I cannot get a full history or physical exam on a questioner, and my answer might be pertinent to someone else and not to the person who asked the question, simply because of my lack of knowledge. Please talk about the relationship between salt intake, blood pressure, and insulin resistance. I've dropped my sodium intake due to blood pressure, but now I find my insulin requirement going up. Well, first of all, let's wonder about your blood pressure. Who is measuring it? Are you measuring it, or is it in a doctor's office? If it's in a doctor's office, there might be the white coat effect, where just being near a physician raises your blood pressure. And we've seen that plenty of times. So, and if you're doing it at home, you might use the latest OMRON, automatic blood pressure device, but you have to be careful. They make devices with a cuff that goes on the finger, a cuff that goes on the wrist. We want the cuff that goes on the upper arm. And the cuff must be the right size for your arm. Usually there are several cuffs available. Why I'm saying all this is because you may find that the sodium intake doesn't affect your blood pressure, and that there's no reason to cut it down. The thing is to get accurate readings of the blood pressure before and after you lower the sodium intake. And when you get a blood pressure machine, you should compare it to the blood pressure taken in a hospital with their device or in your doctor's office. Even if you have the white coat effect, you have two machines side by side. In fact, you could have one on each arm. Usually the two arms are very close together. Now, a drop in blood pressure, if there's really a substantial drop, can lower the peripheral arrival of insulin. In fact, if someone is dehydrated, they're not delivering enough blood to the peripheral tissues because of their dehydration, and insulin will not adequately get, insulin and glucose will not get to the peripheral tissues for delivery into the cells. So it could be that if you end up with low blood pressure, you may have a secondary form of insulin resistance. This form of insulin resistance occurs in people with very high blood sugars, vomiting, diarrhea, who get dehydrated. Their blood sugars can go up just from the dehydration. So it could be that low blood pressure raises your insulin requirements. But this is just speculation. This is a guess. I could be totally wrong in your case. I have a question about reversing type 1 diabetes. Have you found any cases of individuals with type 1 diabetes being able to lower their blood sugars to a normal range, 80 to 120, without injecting insulin, and thereby being able to achieve an A1C under 6? Well, first of all, an A1C under 6 isn't necessarily normal. It depends how far under you go, because an A1C of 6 is an average blood sugar of about 140 milligrams per deciliter. Now, I've seen plenty of type 1 diabetics get their blood sugars under 100 milligrams per deciliter, in fact, even under 90 milligrams per deciliter, but it's always with insulin. I've never seen total reversal of type 1 diabetes. There have been claims of treatments such as islet cell transplants and whatnot, where they take patients off of insulin, but even those studies have not been able to get their A1Cs under 6%. I just wanted to say I'm grateful for the extra years you gave my husband and I together. How can we spread the word to others? Well, you could post my videos on Facebook and on YouTube. You can even add your comments to them. The more replications of videos we get out, the more people can benefit. Can you talk about relevance of glucagon for single people that live alone but nearby family? Where should we leave glucagon kits in the house? Well, first of all, the purpose of glucagon is to treat unconsciousness due to a very low blood sugar. How are your nearby relatives going to know that your blood sugar is very low? Well, maybe if they call you every half hour, or if you have a continuous glucose monitor and they get an alarm, and then they phone you when they get an alarm and you don't answer the phone, that probably is what you're doing. And indeed, it would be a good idea for them to know where you keep the glucagon. Now, there are different forms of glucagon on the market. There are 3 that I know of. There's the powder that comes with a syringe that has diluting fluid in it, so that you inject the fluid into the powder, shake up the vial, and then you inject it into the patient. That powder will last years and years. Even though they put short expiration dates on the package, it's good for 5, maybe even 10 years. There's already pre-mixed glucagon, a liquid that has a preservative in it that supposedly keeps the glucagon active for a good many months. That's brand new, and I wouldn't trust the usability of that for an extended period of time. So the powder you can keep out of the refrigerator. Probably a good idea to keep it in a refrigerator. You might have a little box with a special color on it to identify your glucagon kit, whatever it is, and put it on the top shelf in the front where anyone can see it. There's a third form of glucagon, the inhalable glucagon. And the inhalable glucagon is a powder that comes in a vacuum-sealed package, and that might also be useful for a long time, but I'm not sure. So I'd keep any form of glucagon in a little brightly colored box on the top shelf of a refrigerator, and I'd also keep a small medicine bottle with some Reglan syrup in it in case you're nauseated after you get the shot. We all know that you don't give yourself a shot of glucagon if you're unconscious. And that's why you need someone else to administer it. So it probably would be a good idea to use to keep glucagon at home and to certainly have a continuous glucose monitor that your relatives nearby can get warnings from. By the way, the inhaled glucagon is called Baqsimi, Baqsimi. And I guess if you don't remember the name, you could ask the pharmacy, call it the Japanese glucagon. My kidney blood test showed 37, and I understand 60 is best. Can the kidneys be revived to a higher level? It really depends how far gone they are. What you're probably talking about is the glomerular filtration rate, which is the rate at which the kidneys are filtering the blood. And normal is somewhere around 100, might be 80 to 120, but it's in the vicinity of 100. And a value of 37 might be only 37% of a normal value. Now, there are questions about the accuracy of the glomerular filtration rate. The measured glomerular filtration rate requires a 24-hour urine collection. There's also an estimated glomerular filtration rate, which incorporates the serum creatinine. Doesn't require 24-hour urine, just one blood test, but it has several parameters included, such as your age, your sex, your race, and these are put into a formula that gives an estimated GFR, which may or may not be accurate. So it's very important to know the sequence of GFRs over time. Is it deteriorating? Is it jumping back and forth, etc.? Many years ago, I had advanced kidney disease based upon protein dipstick in the urine. This was circa 1969, and it was just before I learned how to measure my own blood sugar. And about 3 years after I figured out how to measure my blood sugar, I had worked out a low-carb diet, and I had invented basal bolus insulin dosing. So I now had a system that kept my blood sugars normal. And over the next, and I had very high protein in the urine. Didn't tell me my glomerular filtration rate, but it told me that I had advanced kidney disease. The dipstick, 4+ on a dipstick then, was equivalent to in excess of 1,500 milligrams of protein in the urine per day. So that's how advanced my kidney disease was. By normalizing blood sugars, I reversed it, and now when we do 24-hour urines or measure my serum creatinine, I'm in the normal range. But probably, but I can't be for sure, my GFR was probably greater than 37. I don't know what it was. So it's possible to reverse a high GFR, I'm not high, but a GFR that's nearer to normal, let's say 70, 65 maybe. And with my patients, I've seen that patients with GFRs of even 50 deteriorate very, very slowly, whereas those who have a GFR of 15 tend to deteriorate rapidly. The advanced kidney disease perpetuates itself. Can you talk about the relationship between total cholesterol, LDL, and hypothyroidism? Well, first of all, I don't measure total cholesterol anymore because it has no relation. It doesn't do anything that we know of that's adverse. They used to think that it was related to heart disease, but that's when the sweet food companies, including General Mills, Nestle, and a few others, were paying off the researchers to draw conclusions that their research did not disclose, namely blame the heart disease on fat not carbohydrate, because we want to sell a lot of sweet foods. So I don't measure total cholesterol. Now, I don't measure total LDL, but I do look at small dense LDL and and oxidized LDL and some other things that are related to LDL, but not total LDL. In any event, a low free T3, hypothyroidism, can cause increased blood sugar, which can in turn increase the risk of heart disease. The increased blood sugar can increase, for many of my patients, I see them before we lower the blood sugar, and usually and frequently their oxidized LDL or their small dense LDL may be high, and when you lower blood sugar, the bad LDLs go down. That's what usually happens. So now you will see, if you're hypothyroid, if you have a low free T3, you may see a high cholesterol, but that doesn't necessarily mean that you're at increased cardiac risk. You have to look at other tests. What device for finger stick monitors and continuous monitoring do you currently recommend? Well, I currently recommend the Abbott Freestyle Freedom or Freedom Light blood sugar monitoring machines and the Dexcom G6 continuous glucose monitor. Now, Abbott is coming out, already has a continuous glucose monitor that does not give an alarm. The alarm is available in some countries overseas and is expected to become available in the USA. Their rep has been promising it to me for the past 6 months. Every month she tells me next month we'll have it, and we haven't had it. And a continuous glucose monitor without an alarm, to me, is worthless, because the main value to me is to wake me up in the middle of the night if my blood sugar is low. And if there's no alarm, I can't see the value in having the monitor. I've switched to Tresiba insulin and would like to split my dose. Should I take the bulk of the daily dose when I wake up, or should the bigger dose be before bed? What is your current split? Well, right now I take equal doses at bedtime and arising, but that doesn't mean that that's what's best for you. My patients have different splits depending upon the individual. Many of them take a dose at bedtime and a second dose at about 6 or 7 hours later, maybe even 5 hours later. So it's all trial and error. My type 2 diabetics, most of whom take a little bit of insulin, may take a small dose of Tresiba only at bedtime, or they may take it only when they get up in the morning. It all depends when a blood sugar is going up and not controlled by diet alone, or not controlled by diet plus small doses of preprandial insulin. It's all trial and error. I've heard you refer to a potential solution for Dupuytren's contractures, being a hand cream consisted of DMSO and collagenase. Can you please advise further details on the formula for my compound pharmacist and methodology of application? Well, first of all, the well-tested cure is for a hand surgeon to inject collagenase directly into the contracture. Usually, Dupuytren's contracture is accompanied, it involves claw hands, and it's accompanied maybe by a huge lump, maybe the size of, could be the size of an almond to the size of a walnut, on the flexor tendon of the fourth finger. Some of these people with multiple Dupuytren's may have lumps on each flexor tendon. In any event, what the hand surgeon does is injects collagenase. This is an enzyme that dissolves collagen into the lump and administers small multiple doses spread out over time until the lump disappears. The procedures are usually very expensive. If the surgeon doesn't charge very much, it may be covered by Medicare, but at the prices they've been charging, it probably isn't covered by Medicare. What I discovered that I used on one friend, I didn't even use it myself on him. His son was a physician, and I told him the formula to give to his son, and indeed it was effective for him. And this was 6 parts of 99% DMSO, dimethyl sulfoxide, as a diluent to 1 part of collagenase. The DMSO is absorbed directly through the skin, and if you put the mixture in a bottle with a brush, like a nail polish bottle, you tell the compounding chemist, put the mixture in a bottle with a brush, and then you brush the solution onto the lump will gradually get smaller, or in this one case it did. And we had to do it, he had to brush it on, I told him, 4 times a day, and it took over a year to get the size all the way down. My A1C level is currently 5.6. My doctor put me on a low-carb Mediterranean diet 1 year ago. I eat steel-cut oats every morning. That's high carb. For the rest of the day, no carbs, just vegetables, fruit, and protein. Well, the vegetables could be high carb, could be low carb, and the fruit certainly is high carb. So this person who thinks he's on a low-carb diet appears to be on a high-carb diet. How do I get my A1C level to get lower without losing more weight? Well, first of all, I would cut back on the carb, and add more protein. And you might have to add a lot of protein to prevent losing weight. Furthermore, you might even need insulin. Your A1C level is a little on the high side, so there's a good chance that you may need insulin, but not a certain chance, because it's not that high, and eating oats and fruits might well get the A1C down to normal. But if you're losing weight when you eliminate the juice and the oats and fruits, then you may need insulin. And if you're going to eat insulin, read my book, Diabetes Solution. I'm 33-year-old type 1 for 15 years. I have stage 3 chronic kidney disease, and my creatinine is 4.2 milligrams per deciliter, which is pretty high. My nephrologist advised me to limit my proteins. Can I follow a low-carb diet? Well, I would say that you discuss it with your nephrologist. He knows that chronic kidney disease, probably in your case, is caused by high blood sugars. And if you're going to be on a high carbohydrate diet and have high blood sugars, there's a good likelihood you're going to accelerate kidney deterioration. There have been occasional studies done where protein intake was limited in people who have GFRs around 5 to 15 milliliters per minute. And what they find is that it might slow the serum creatinine increase for a couple of months, but then it continues at the prior rate. So it's a tough question. My guess is that the high blood sugars will have more of an effect than the protein. And lowering protein, of course, is only of potential value in advanced kidney disease. For people with normal kidney function, you don't want to cut back on the protein and increase the carbohydrate. Does this is the question about creatinine and cystatin C. Okay, well, that I already answered. I'm a type 1 diabetic with hypertension, that's high blood pressure. I follow your books, and my last three A1Cs are 4.8, 4.7, and 4.7%. In the last year, my estimated GFR rose 13 points. That means his kidney function improved. Now it's above 100, due to blood sugar being in the normal range. Can I expect to see further repair to my kidneys, leading to reversal of my high blood pressure? Well, first of all, although there's a good chance that kidney disease can cause high blood pressure can cause kidney disease. And I've not seen your tests, I've not examined you, I don't know what the cause of your kidney disease was. So I don't know if normalizing the kidney function is going to reverse your high blood pressure. There's a possibility that it can. My 6-year-old has type 1 diabetes and refuses your dietary approach and is always sneaking goodies. How can I convince him to eat like the other kids we see on the type 1 grit who are doing so well? I think she wants him to eat like the parents of the other kids on type 1 grit. And this is, my philosophy is that if there's a type 1 diabetic in your family, everyone should be on a low-carb diet for two reasons. One, you don't want that kid to feel all alone and different from everyone else. He's got enough differences as it is. Secondly, there may be people in the family who are pre-diabetic genetically, and you want to reduce their chance of getting diabetes. But if there's a parent who finds that his interest in goodies exceeds his interest in the well-being of his child, then there's something significantly wrong in the family. And I think the family needs some help because something not good is going on. I'm wondering if Dr. Bernstein can share his experience using his approach related to reversing eye floaters. Well, eye floaters are very common, especially as people age. They may have nothing to do with diabetes, or they may be due to several significant problems in the retina. A very common cause of floaters is peripheral vitreous detachment, where as we age, the vitreous humor, which is the liquid in the back of the eye that touches the retina, it starts off as a liquid, but ends up over time as a gel that becomes thicker and thicker. And eventually, it may stick to the retina, and you may do some activity like jumping on a trampoline that shakes the vitreous around, pulls on the retina, and causes a tear. And peripheral vitreous tears are especially common in high myopes, people who have severe myopia, nearsightedness. Their eyes are more elliptical shape, and just the shape of the eye can cause the vitreous to pull on the retina, and they can get floaters. They can even see little black dots or blood cells skittering around their field of view. They don't skitter around. They tend to be sort of stationary. But floaters can have a lot of causes that aren't necessarily caused by diabetes. And once you have a floater, controlling your blood sugar isn't going to make it go away. If it's caused by some form of retinopathy that gets better with blood sugar control, then you might not make more floaters, but you're not going to make one go away all of a sudden. Sometimes these floaters redissolve. Is the low-carb, high-protein diet good for 5-year-old? Are there extra supplements or minerals the child should take? Well, this questioner put in the 6, 12, and 12 on the carbohydrate, but that's for an adult. For small people, we reduce the carbohydrate in proportion to their weight. Now, anyone on a low-carb diet should still be getting vegetables. And in my book, Diabetes Solution, there is a table of maybe 30 or 40 low-carb vegetables, and there are probably many more that aren't even in that table. So there are plenty of low-carb vegetables to choose from when giving meals to a child. Children certainly need vitamin D, and unless you're living in a tropical climate and are out in the sun frequently, you being the child, you're probably not getting adequate amounts of vitamin D. And for bone growth and development, kids need vitamin D. So your pediatrician should be consulted, and he probably should be prescribing vitamin D supplements. There are a lot of parents concerned about ketones, and there doesn't seem to be a clear answer that would give some relief. Is it normal for a child that's on a low-carb 6-12-12 to have ketones? Well, first of all, if it's a small child, it's not 6-12-12. You have to go back. Now, many people who are not on a low-carb diet may have ketones in their urine just from fasting overnight. Pregnant women frequently have ketones in their urine because there are two individuals trying to metabolize the fat that was stored away during pregnancy. So during the first 3 months of pregnancy, you're building fat, and later on in the pregnancy, you're metabolizing it. And that's going to make ketones. The ketones aren't harmful. As I've explained over and over, ketones are responsible for the survival of the human race. And yes, if you have very high blood sugars, which will cause dehydration, and since the kidneys like to pee away ketones, if you also have ketones, high ketones, with high blood sugars and vomiting or diarrhea, so you're getting dehydration from all directions, then you're concerned about the ketones. But in ordinary life, just because you're metabolizing fat overnight, you shouldn't be worrying about the ketones. Now, if a child is losing weight, including the loss of fat mass, and if he's not supposed to be losing weight and is showing ketones, then he's not getting enough food and he's not getting enough insulin. So it's a complicated sort of thing, but being focused on ketones is the wrong focus. You should be focused on blood sugars. And if blood sugars are normal and the kid is growing along his historic pre-diabetic growth curve, you can forget about the ketones. I cannot remember when I last tested myself for ketones. It was in the days before we could measure blood sugar, when if you had a lot of glucose in your urine, you were supposed to test for ketones, because that would tell you if you had a super high blood sugar. So it's been, I'm sure, more than 50 or 60 years. Okay, here's a nice question. Currently, I am eating 4 eggs per day. Is it okay to eat 4 eggs per day, or should I reduce the number of eggs per day? Well, if you want more chickens, eat less eggs. Let them hatch. I've seen reports that double diabetes is increasing in type 1 diabetes, and even kids. Is it really possible for a type 1 diabetic to develop type 2 diabetes? Well, type 2 diabetes, by one of the definitions, involves insulin resistance. And there's even been claims by some authorities that type 2 diabetics may be making excessive amounts of insulin because of their insulin resistance. Now, if you feed a type 1 diabetic a lot of carbohydrate and give them a lot of insulin to cover the carbohydrate, as until recently was recommended by the ADA, now they're on the fence, but most endocrinologists are still pushing high carbohydrate and high doses of insulin. That will frequently make the kids fat, and making them fat can cause insulin resistance. And insulin resistance is to many equivalent to type 2 diabetes. So yes, you can cause type 2 diabetes in type 1 kids, and this is very common because of what the doctors are doing in the way of dietary recommendations. These kids, however, are not likely to be making excess insulin as many type 2 diabetics do because they're type 1 diabetics. So they're type 1 diabetics with insulin resistance, and therefore it's said they have type 1 and type 2. Does vitamin D increase insulin sensitivity? There are a number of articles that show that type 2 diabetics seem to have lower vitamin D levels, but by giving them replacement vitamin D supplements doesn't seem to increase their insulin sensitivity. So I've seen a number of studies over the years, but no indication that vitamin D supplementation improves insulin sensitivity. But for those who are not exposed to the sun, it's probably a good idea to check your serum vitamin D3 levels, and if they're deemed by your doctor to be lower than they should be, to give supplemental vitamin D to get them up to normal. By the way, it takes about 6 months for the serum vitamin D level to reflect the supplement, which is stored in fat. My insulin requirements seem quite high, about 40 units per day, but I'm lean and athletic. Are there any blood tests I can get to confirm if I have a hidden infection? Well, first of all, you may be slim and athletic, but if you're 6.5 feet tall, you may require weigh over 200 pounds and require 40 units of insulin. So depending on your size, this may be a reasonable dose of insulin. Now, the blood tests that you can take looking for infection include C-reactive protein, complete blood count with differential, and if you have an infection, the neutrophils might go up. Procalcitonin sometimes can tell you if you have a bacterial infection. And let's see. Oh, an erythrocyte sedimentation rate, also called a SED rate, that might disclose infection also. The SED rate, by the way, would most properly be done in the office where the blood is drawn, rather than waiting many hours for the blood to go to the lab and be tested at the lab. And the kits for measuring sedimentation rate most doctors have them in their office, and if you go to a major laboratory, they probably have the SED rate apparatus in the office there. I've noticed a kind of cognitive dissonance that occurs when I tell endos I am on low carb and show them my continuous glucose monitor graph. What is the root cause of this emotional reaction? I think that the cognitive dissonance that this patient is noticing is on behalf of the endos, not on behalf of the patient, I guess. And endos don't as a rule, I can't speak for all of them, but based upon the many patients I've spoken to, the endos don't like normal blood sugars. And when they see normal blood sugars in a straight line, as on many of the CGM curves for people who are following my guidelines, they don't know what to say, because they want to say you should be on a high carbohydrate diet, and they want to say that your A1C should be high, but when they see a flat horizontal line, they're dumbfounded. That's just a guess on my part. My doctor tests for every thyroid marker except free T3. How can I convince them to get this tested? Well, there's a very interesting, very educational article on deiodinases. These are enzymes that affect thyroid hormones. And you can find this article on the following site. It's called NA for National Association, nahypothyroidism.org. And if you can get your doctor to read the article, he'll get a good education, but he'll also get an understanding of why T3 is the hormone that affects the way we feel and the way our body responds to thyroid treatment. Newly diagnosed type 1 here. Can you give us your top 3 reasons that we should follow your protocol? It seems like giving up my favorite foods is going to ruin my life. Well, that's pretty hard to believe, especially since it's very easy for diabetes to ruin lives if it's left uncontrolled. So, here are some reasons. Normal blood sugars lower the incidence of kidney, visual, heart, kidney disease, eye disease, heart disease, stroke, dementia, and amputations. So that's a list of good reasons to have normal blood sugars. Our endocrinologist advises us to put our daughter to bed at 200 milligrams per deciliter so we can sleep through the night. If she's below that, they suggest a snack to get her blood sugars up. Will this do damage? Well, first of all, you can do a search for some of the articles that I've reported on during my teleseminars. There are many articles about brain damage in children due to high blood sugars. And you could do a literature search and hand your endo a stack of articles about the damage that high blood sugars do to the brain. You can get a continuous glucose monitor, and if you're lucky, it'll only wake you up when her blood sugar is too low. And I suggest you read my book, Diabetes Solution, because what your endo is used to is the up-down blood sugar swings that he typically sees on the children that he's treating, because he has them on high insulin doses and on high carbohydrate diets. When you're on a system that's geared to level blood sugars, you're not going to see those kinds of swings. You lower the risk. But you still must have a continuous glucose monitor. That and that's not just speculation. Most of the answers to my questions are guesses, but a continuous glucose monitor for a child is a must. And that's a monitor with an alarm. And the alarm should occur in your bedroom. By the way, it's also a good idea to have a small child, sleeping in your bedroom. Can you tell us your favorite breakfast and favorite dinner? Well, I'm not big on eating. I'm very busy and don't have time to prepare to be a chef. And my companion, Joyce, is likewise not a chef. She cooks, but she's not a chef. So I eat what's easy. And what's easy for me is at breakfast, smoked salmon, cream cheese, and pistachio nuts for the carbohydrate. And for dinner, I have some sliced corned beef, some sliced pastrami, about a half of an avocado, some Limburger cheese, and a small salad.